So can you all hear me? I think the microphone is on, isn't it? Yes. Okay. So before I start, I want to thank Mark for inviting me to speak here. Like he said, I'm very excited to be here because I learn a lot from you, as well as hopefully you'll learn something from me. But I do have to make one complaint, that you're making me follow Sue and Elizabeth, who gave such a fantastic talk. It's a hard act to follow. But I do want to disagree with one thing that I think Elizabeth said, that you should complain if you're not happy about your care. We know that all the staff in the NHS are working really hard, but we're working in tough conditions, and the Marsden is no exception. We are too. But the only way that the system changes is if we hear from the patients. The managers don't listen to us. They listen to the patients making formal complaints. So we want the complaints to come in, because then that gives us the impetus to change the department, to make the care better for you all. So that's one of my big take-home messages today. So before I start, I just want to gauge how much of an expert audience you are. So how many of you have CLL? If you could just raise your hands. So pretty much most of you, and I assume the rest of you are friends and family. And how many of you have been to one of these conferences before? Okay, so quite an expert audience. And how many it's the first time that they've been to it? That's quite a few as well. Okay, so we've got a real mix. So it does mean that I'm going to go through stuff that may be a bit basic for some of you, but just to get everyone up to speed. And then the other thing to say is that what I'm telling you now may not hold true in even next year, definitely 5 years, definitely 10 years. So what I hope through this talk is, although I'll present the evidence as it stands now, I want you to be able to understand how we interpret the evidence, so that when you go to educate yourself, as Sue said, that you know what to look for in the trial data, so that you know you're getting the best care. Okay, so I've changed the title of the talk from what's been put in the schedule, because I think this is a much better title, because I don't think we can talk about treatments now and in the future without seeing where we came from, because it does have an impact as to how we manage patients now. And I thought management is a much better word than treatment of CLL, because it's not just about giving the chemotherapy or the ibrutinib for CLL, it's managing the patient as a whole, and I will touch on that. So just to put it in context, blood cancers are the 5th most common cancers, but they are the 3rd biggest killer in the UK, and this is all leukemias and lymphomas. And they are definitely, and no offense to all of you, happen when people grow older. So CLL specifically in the UK, there's about 3,500 to 4,000 cases a year, and about 1,000 deaths from CLL in the UK yearly. And you'll see that this graph shows the age at diagnosis, that it's more common in men, the blue bars, than it is in women, but that certainly most people are diagnosed in the 60s, 70s, and 80s. We do know that over the time, so this is people being diagnosed in the 90s compared to now, that the incidence of CLL, so how frequent it's occurring, is slowly increasing. And that's not just because the population is aging, it's increasing in all age groups. So where does CLL come from? So all your blood cells come from your bone marrow, and in your bone marrow you have blood stem cells, which we call pluripotent. They have the ability to keep dividing and to differentiate into all your different types of blood cells. But essentially, they will either divide into myeloid stem cells, which eventually become your red blood cells, your neutrophils, and your platelets. So when you look at your full blood count, that's what we're looking at, the mature myeloid stem cells, and your lymphoid stem cells, which become your B lymphocytes and your T lymphocytes. And basically, any one of these cells has the ability to become cancerous. And depending which one it is how we define or classify our different leukemias. So an early myeloid stem cell that's become cancerous would be an acute myeloid leukemia. But onto CLL, this is a cancer of the mature B cells. Now, it's not the only cancer of mature B cells. There are, on the latest WHO classification, which came out in 2016, now over 40 different types of mature B cell cancers. And you can see CLL is at the top there. So how do we diagnose it? So first of all, we generally see, and most of you probably will have been picked up from having a full blood count, perhaps for another reason, and the lymphocyte count was raised. So we see that the lymphocyte count is raised, and we want to see whether all the lymphocytes look exactly the same. So the main function of the lymphocytes in normal, everyday life is to fight infection, and the way they do that is they all look different to each other so that they can fight different infections. But one of the hallmarks of cancer is that all the cells are clonal. They all look exactly the same. And we can pick that up from something called immunophenotyping. So you might hear people talk about flow cytometry or immunophenotyping. So basically what we're doing when we do a flow cytometry of your blood or your bone marrow is that we're looking at the proteins that are on the surface of the cell. And we can basically incubate the blood cells with different fluorescent antibodies that will attach to the different proteins and see whether those cells have those proteins or not. So we do that to prove that the cells are clonal and to differentiate CLL from some of the other mature B-cell malignancies. So we get plots like this, where one of the proteins on the cell surface of CLL cells is a protein called CD5. If your cells have CD5, then they'll appear on this side of the graph. So these ones are all positive for CD5. And we can compare, do these cells also have CD23, another protein that we see on CLL cells. So the majority of these have both CD5 and CD23 because they're in that top right corner. If they had neither, they would be down here in the bottom left corner. So we can use this to help us diagnose CLL and separate it from other types of chronic B-cell malignancies. And there are certain proteins that we know are associated with prognosis. So once you've been diagnosed, we'll talk shortly about the prognosis. So we use that to help with that. And then we can also look at it down the microscope, which we did way before we had flow cytometry. And the typical things we see down the microscope, so these things here are all your red cells. These little tiny cells here, or fragments of cells really, are your platelets that help your blood clot. And these are your CLL cells here. And CLL cells are quite fragile, so when we spread it on a slide to make a film like this to look down the microscope, we get this characteristic smudge cells or smear cells where the cells break, basically. So that's how we diagnose it. So once you've been diagnosed, the next thing we talk about is prognosis. Now, prognosis means different things to different people. The way I think about prognosis generally is that it basically means how long do we expect you to live for, essentially. And we use lots of different factors to be able to help us decide on prognosis. So there's patient factors. So it's different if you're 30 being diagnosed with CLL compared to 95, for example. Your gender makes a difference. If you've got other illnesses, the heart conditions, diabetes, high blood pressure. We know that there are also disease factors, and we're learning more about this all the time. So different things about your CLL compared to someone else's CLL that will have an impact on the prognosis. And we also know that actually how people respond to treatment also has an impact on the prognosis. So what is a prognostic marker? I've said that one of the things I think about is it predicts how long someone's going to live for, so their overall survival. But also it would be useful for people to know from these factors whether they'll ever need treatment. So there are a proportion of people who've been diagnosed with CLL who will never need treatment for the CLL. Now, we can't tell you which proportion of people that would be, but it would be nice if we had something that would help us tell people, because it could help you plan your life. And if you are going to need treatment, can we give you any idea of how long it's going to be until you need treatment? And because there are lots of prognostic factors, lots of people have looked to see, well, if we combine them together, can we come up with a more accurate prognostic index? and I'll talk about one of the bigger ones shortly. But ultimately, our aim is that we want to turn prognostic markers into predictive markers. I don't really, in a clinic, want to say, you've got this bad prognostic marker and this one and this one. So I'm going to give you treatment, but I know you're not going to do as well as someone else who doesn't have those bad prognostic markers. I want to use those tools to be able to change my treatment to give you, to say, I know that you're not going to do well with this treatment, so I would rather give you this other treatment, which I think you will do better on. So our ultimate aim is not just to be able to tell you, we think you're likely to live for this long. We want to use the tools and use our knowledge of the biology to be able to help personalize the treatment that we give you. And the other thing to say is that prognostic markers are based on studies from many, many years ago. One of the problems of CLL is that it's quite an indolent disease, so that many people live many, many, many years with it. So it does mean that when we're looking at trials for prognostic markers, these trials have to be going for decades before we really get a readout. So when we talk about prognostic markers today, we're basing it on trials that were done in the 90s, early 2000s, but treatments have changed since then. So things that might have been relevant at that time may no longer be relevant now that we've got ibrutinib, venetoclax, etc. So the old-fashioned, but still in use, prognostic marker was based on just purely clinical staging. And there were the two main ones. So there's the RAI and BINE, but both fairly similar. So the RAI, your stage 0, is when you've just got increased lymphocytes in the blood or the bone marrow, but don't have enlarged lymph nodes, and that's just by clinical examination. So it's not doing a CT scan, but we can't feel any enlarged lymph nodes, enlarged spleen, or enlarged liver. And then the highest, stage 1 and 2 is when you've got enlarged lymph nodes and a large spleen, which is splenomegaly, and an enlarged liver, or an enlarged liver, which is hepatomegaly. And then 3 and 4, the worst stage, is when it's affecting your normal blood count. So your hemoglobin is down, that's when you're anemic, or your platelets are low, and that's when you're thrombocytopenic. And I should say that this is if we've excluded autoimmune causes for the low blood counts. And this is looking at big population data, and again, like I said, this is from studies from decades ago, so may not be as relevant now, but in these studies, the overall average survival, so when we talk about median survival, it's how long do the population who have this RAI stage 0, how long do 50% of that population live for? That's when we talk about what we mean when we talk about median survival. And 50% lived for greater than 10 years with this RAI stage 0. And then it gets increasingly worse as you go up the stages. And similarly with the BINE, it's based on how many areas of enlarged lymph nodes you have. And then the worst stage again is when your normal blood counts have dropped. But we've become more sophisticated now. We're learning lots about the biology of the disease. So now there's loads more prognostic markers, and this is just a very short list. I could give a week's course just on prognostic markers. But these are some of the more important ones, and even some of these are going out of fashion. But I'm going to highlight a couple of them because they do have relevance now. So the 17p deletion, the mutation TP53, and the IGHV rearrangements. But there are so many different prognostic markers. So let's talk about immunoglobulin V gene mutations and rearrangement. So normal B cells, as I said, their normal function is to fight infections. And so they produce antibodies which help fight these infections. And all the antibodies have to be different to fight different infections. And the way that your B cells produce different antibodies, because remember, your DNA is the same in every single cell, so it's quite a neat thing, but basically the DNA that codes for the immunoglobulins, you have this region, which is the variable region, which is VDJ, that basically your B cell gets exposed to an antigen, which is a protein, a foreign protein, it could be an infection. Then the antibodies that are on the B cell undergo this germinal center reaction, so they switch class, and then the antibodies, they deliberately, this area on the DNA, deliberately undergo something called somatic hypermutation, where they develop mutations in the genes to make them all very different to each other and to increase how well they bind to the antigen, to the foreign protein, so hopefully get rid of it. What we know is that if we look at patient CLL cells and that their cells have undergone, or the somatic hypermutation, so that how close they are to the original B cell is less than 98%, that the overall survival is much better than those who have this unmutated gene rearrangement. So we generally, and I think it is British, in the British guidelines, that you should check for this because it does give patients information about prognosis. So, mutated versus unmutated. So what we know is that those that have got the mutated IGHV have a slower growing disease. Many of them never need treatment. They tend to respond very, very well to our traditional gold standard treatment, FCR, which we'll talk about shortly. And they're less likely to develop other genetic change. Whereas those who've got unmutated disease usually need treatment, and they respond very well to treatment, but that response doesn't last as long, and they're more likely to develop other genetic changes. So, cytogenetics. So, we've diagnosed someone, we want to see for the prognostic markers, and one of the things we look at is you'll hear people talk about cytogenetics, karyotype, and FISH, which are different ways that we can assess the cytogenetics. So cytogenetics is basically looking at all the chromosomes in your CLL cells. You know that in every cell, you've got 23 pairs of chromosomes. We can take CLL cells and grow them up in the lab and basically look to see what your chromosomes look like in the laboratory. And see if there's bits that are missing, bits that have been moved to a different chromosome. And one of the key things that we can see in a small proportion of patients with CLL is that there's a part of the chromosome 17, so this is the P arm, so you've got P arms and Q arms, that often, well, in a small proportion, I should say, of patients, part of the chromosome 17 is missing from one of their chromosomes. They're called a 17p deletion. And we do see other chromosome changes as well. So someone might have deletion of the Q arm of chromosome 13. Some people might have normal cytogenetics. And some of these changes are, again, associated with prognosis. So we know that people who've got 17p deletion, the survival is not as good as people who don't have a normal karyotype. And this, again, is based on data from people having chlorambucil. So whether it still holds true now, difficult to tell. We don't know with newer treatments whether this will still be relevant. It's sometimes hard to do karyotypes on CLL cells because they don't grow well in the lab. So in a lot of centers, we perform something called FISH instead of a karyotype to look for the same information. And that's basically using fluorescent markers to bind to areas of the chromosomes that we know might be deleted. So here is analyzing for 17p. And as I showed you before, you've always got 2 pairs of chromosomes. So you can, I don't know how well it shows, but if you see the red marks here, this is a normal cell because it's got 2 17p marks. This one's a normal cell here, but you'll see some of the cells only have 1 mark, which means that the other one is missing, so that they've got the 17p deletion. So that's looking at things from the chromosome perspective. But we also know in CLL that there can be mutations, so little changes on the DNA that you wouldn't see from looking from the chromosome perspective. So this is looking much closely at the genes themselves to see if there have been changes that have stopped them functioning. So for example, 17p, we know that one of the main reasons it's associated with a worse prognosis is that you're removing a gene called TP53, which is what we call a tumor suppressor gene. It holds cells in check and it stops them from just continuously dividing. So as well as having a 17p deletion that's associated associated with a poorer prognosis. You could have a mutation in the gene which stops it functioning. So when you get, when you come to needing treatment, you should all, and this again is British guidelines, have a FISH to look for 17p deletion and a mutation status. So you need to see both of them because you may have one or the other, so you might not pick them both up from one test. So this is basically showing you the same thing, so that you could either have a mutation in the gene or the gene just could be missing because the whole section of the chromosome is missing. But both of those have been shown to be associated with a worse prognosis. So that's TP53, which we know is associated with a worse prognosis. But Landau, an American group, published in Nature 3 years ago, they looked at whole genome sequencing. So not focusing just on one gene. They took over 500 patients with CLL, and they looked at their whole gene, both from a chromosome point of view and also at all their genes to see whether there are mutations in their genes. So just to take you through this diagram, each column is a different patient, and each row is a different gene or chromosomal abnormality. So the ones in blue are the chromosomal abnormalities, and the ones in black are mutations in those genes. So you'll see that there are certain ones that are quite common in a lot of patients. So in their cohort of patients, they had quite a few who had a deletion 13q. TP53 is down here, and there were quite a few that had that. But the whole take-home message is that everyone's CLL was quite different, that actually lots of people had lots of mutations in different genes, and they were different to someone else's. So when you start to see how different everyone's CLL is, you think no wonder people don't respond in the same way to the same drugs. And who knows, I've showed you that now in our WHO classification there's 40 different types of B-cell neoplasm. Who knows, in 50 years' time, what we now call CLL may also be considered 30 different diseases as we learn more about them. So we're definitely understanding more about how different everyone's CLL is. But what to do about it, we don't know yet. But anyway, so this is going back to the prognostic index. So we know that there's different things that are associated with a poor prognosis. Can we group them together to give you even more valuable information? So this was a big study published in the Lancet Oncology a couple of years ago, looking at and they called it a CLL-IPI, International Prognostic Index. And they looked at this, they studied it in over 3,000 patients, so quite a very large study. And they basically looked at 5 relatively simple prognostic factors. What's your TP53 status? What's your IGHV mutational status? What's your serum beta-2 microglobulin clinical stage? So again, still keeping the Rye and Binet stage in, and how old are you? And then it came up with a different score, and it was weighted for the different prognostic factors. So this one was weighted far more heavily than some of the others. And then they could classify people into 4 risk groups, from low risk to very high risk. And they showed that this helped classify people both in terms of how long they're likely to live for without needing treatment, and also that how long they're going to live for, period. So people in the low risk group did much better overall survival-wise and time to first treatment-wise than people in the very high risk group. Okay, so we've diagnosed a patient with CLL. We've talked about some of the prognostic factors. And as you're probably all aware, that most of you will, once you're diagnosed, be told, we've diagnosed you with CLL, but we're not going to do anything about it just yet. We're going to watch and wait, that dreaded phrase that I know many people don't like. So what's the evidence? What's the scientific evidence behind watch and wait? So again, this is a study that was done a long time ago based on when we only had one drug really to treat CLL, chlorambucil. And what this study did was in about 600 patients, they randomized patients to having no treatment if you were asymptomatic, to having chlorambucil as soon as you were diagnosed. And they found that the overall survival was no different to having treatment straight away to just waiting until you needed treatment. And this was also seen in another study too. Okay, but that's in all the patients. But I've already told you that there's some patients that we know are high risk. So is that still the case for all patients, that we should wait until people become symptomatic? So this study was again based on trials from now 20 years ago, but only just published last year in terms of the long-term follow-up. So it takes a long time to get the answers to this. And they basically decided low-risk patients were going to watch and wait. But those patients that we know are high risk, we're going to randomize those patients to starting treatment as soon as they're diagnosed or watching and waiting. And they randomized them to either having fludarabine chemotherapy or watch and wait. So the yellow bar is the low-risk watch and wait. And the green bar is those that were high risk who started fludarabine. And the blue bar is those that were high risk that were watch and wait. So let me take you through these graphs. You're going to see a lot of survival graphs today. So I just want to make sure people understand them before I talk about the results of them. So always on these survival graphs, on the x-axis is the time. So you need to see, is the time in months, is the time in years, and also how long the time is. So some studies will have excellent graphs, but if their time point here is only 24 months, it has less meaning, or less power rather, I should say, than one where you've got over 12 years survival data. So this is long-term survival. And then you need to see is what are they looking at? What is their survival data? So we have different survival terms. So overall survival is how long someone lives for. But a lot of these will have progression-free survival. And progression-free survival means how long will someone live for before their CLL comes back. And some curves will have time to next treatment. So how long will someone live for before they need their next treatment? And it can change things, which I'll show you on these two graphs here on the left. So here was the first readout, which is progression-free survival. So if we just concentrate on the green line and the blue line here, so you can see that the patients that were high risk, that were watch and wait, perhaps very logically, had less time until they needed treatment or next treatment, whereas those who had fludarabine had a longer time until they needed their second treatment. Perhaps logical. One group of people have had treatment, so they'll have a few more years before needing their second. And this is how many years the high-risk patients waited till they needed their first. But that did not translate into a better overall survival. So that's the key thing for people, is that sure, it might, taking fludarabine up front if you're high risk may lead you to have a longer time until you need your second treatment, but actually it didn't make a difference to how long someone lives for. And so this is really why, at this moment in time, we suggest watch and wait. I should also say that things, what we say now may not hold true in the future. So now that we've got these targeted therapies, does watch and wait, is it still the right thing to do? And no one can answer that, or we don't have the evidence to answer that. And there are studies looking to see now whether watch and wait is the right thing to do. I think there's a study in the US, a small study, looking at giving ibrutinib straight away as soon as someone's diagnosed, even before they've got symptoms. But I guess the thing to think about is that the treatment we give can also change the biology of the disease. So actually, it may be worse to give treatment straight away because you're changing the disease, you're making it progress and evolve into something perhaps more aggressive than if we didn't give any treatment at all. So that's something to think about. And the other thing that I just wanted to highlight from a different disease group but has a lot of similarities to CLL or parallels is follicular lymphoma. So it's another indolent lymphoma, B-cell malignancy, that we also have watch and wait for. And so there was a study, a UK study for follicular lymphoma, where they randomized patients to watch and wait or just having maintenance rituximab. And again, the time for the patients to need treatment in the watch and wait arm was less than patients who had rituximab. Understandable. One has had treatment, one hasn't. So you'd expect them to, the people that have had treatment, to have a longer life before they needed their second treatment. The progression-free survival, so how long someone lived for until their disease progressed. Again, this group had treatment, this one hadn't. So understandable that they had a longer time until they needed their second treatment compared to when they needed their first. But the key thing, again, no difference in overall survival. But NICE have approved rituximab on its own as a single agent based on this study, even though it doesn't have a difference to overall survival. And the reason NICE approved it was based purely on health economics. So they knew that if we treat some patients who are asymptomatic, who we normally wouldn't treat with rituximab, and could have them living for a bit longer before they needed their full treatment, which is more expensive, then many of them will die from unrelated causes in the meantime, and so the NHS benefits from a purely financial perspective. So it's just something to think about when the health economics for things that drive which drugs that they approve for use and which ones they don't. Okay, so one of the reasons, like I said at the beginning, that I changed the title of the talk, that I think that we should be not just thinking, and as doctors we're probably the worst at this, about the treatment of CLL. It's not just about giving the chemotherapy or the targeted inhibitors for CLL. We should be managing the patients much more holistically, and I have to confess, we're not great at it. We are getting better, and we're realizing that we need to do it, and part of it is being in a multidisciplinary team. One of the main things that I think is great about the Marsden are our CNSs. Our clinical nurse specialists are fantastic, but we could do better. I think we need to improve our psychological support and other things as well. So when we talk about managing CLL, which I'm not going to focus on much, but mental health is an important issue. It is. We know that people get very anxious, they get very worried about the diagnosis of CLL, and perhaps we underestimate it in the clinic and we just concentrate on the clinical side, is the CLL progressing or not? Physical health is important. I would always recommend, it's not going to change the biology of your disease, but it's important to try and stay active. It's important if you smoke to try and stop smoking, and you can get help with that. And there are other things that we know are important. So we know in the UK a lot of people are vitamin D deficient, but actually there have been big studies now which have shown if you're vitamin D deficient, your outcome with chemotherapy is less good than if you're vitamin D replete. So we should be checking these. We should be giving supplements if people are deficient. And then obviously there's also the complications of CLL as well. So it's not just about, is your CLL progressing or not? Are you getting lots of infections? Are you getting admitted into hospital a lot for them? Can we be doing better from that point of view? We know patients with CLL are more likely than the general population to get other cancers. So it's important you know that, so you can look for skin cancers, but it's important that we also look at those things as well. And so I would recommend any screening that you definitely do it. And then there are also the autoimmune complications as well. So I'm not really going to talk about those, but it's essentially, we know that CLL is essentially a cancer of one of your immune cells, and that you're at a higher rate of getting autoimmune complications where your cells attack your own body. They recognize them as foreign, and they can attack different cells. So some people might have autoimmune hemolytic anemia, where your B cells are attacking your red blood cells, causing you to be anemic, and there are other autoimmune conditions. So we need to be better, I think, at focusing on all these things. And I thought, I've apologized, this is a very wordy slide, but I wanted to say it and I wouldn't remember it, and I can't say it as eloquently as this, but basically we have a big hematology conference, or the biggest hematology conference is in America, called ASH, every year in December, and each year ASH produce an education book, and the one from last year, that's from 10 years ago, sorry, had an article on the impact of CLL on quality of life. And so they said in it, a new diagnosis of CLL has an profound impact on quality of life, even among patients without clinical symptoms. In addition, the uncertainty as to how rapidly their disease will progress, these individuals must deal with the diagnosis of a medical condition that will likely shorten their life, place them at risk for a number of disease-related complications, is managed with toxic therapies for those needing treatment, and can have significant social and financial implications for their family. While it is based on the best available evidence, the watchful waiting strategy often leaves patients feeling that they have a serious health problem, but that nothing is being done to treat it. And I think we could all learn from this. So we are beginning to be better and more scientific at exploring the impact of CLL or the diagnosis of CLL on quality of life, but we're still nowhere near as much research into this as into treatments of CLL or prognostic factors. But this was work done from a good few years ago now, looking at the impact of a diagnosis of CLL on patients' functioning and on their symptoms. And we know, compared to an age-matched population who don't have CLL, that consistently in every aspect of life, patients with CLL, and this is even when you don't have symptoms, had worse scores in physical activity, social interaction, emotional issues, cognitive issues, and had many more symptoms just generally. And obviously fatigue is a big one, even in the absence of anemia. But what we do about that, difficult to know. There have been studies to see whether being on treatment makes a difference to people's quality of life rather than the anxiety of watch and wait, and actually it doesn't seem to make a difference. But we know there are certain things, such as people who get diagnosed with CLL when they're younger, they seem to be more anxious than people who are older. So I'm just going to touch on one slide, I think, on the complications of CLL. So I mentioned one of them, increased risk of infection. So one of the things that you can do is make sure that you try and reduce your risk of complications as much as possible. So vaccinations, flu vaccine every year. That's what we recommend. The pneumococcal vaccination. Now, we know that CLL, because it affects your immune system, it does affect your response to the vaccination. So we're not saying don't have the vaccinations, but we know that it might not be as effective in you as someone who doesn't have CLL. And there have been studies which have shown that specifically with the pneumococcal vaccine, there's two different types. There's ones that are usually given to adults, and there's ones that are usually given to children, that people with CLL seem to respond better and mount a better immune response to the children's one. So the recommendation is to have that one first, followed by the adult vaccination. But GPs aren't used to this, and as I think Sue mentioned, it is about educating the GPs who have to deal with so many different diseases about things like this in conjunction with your hematologist. Avoiding live vaccines. Now, this isn't exhaustive. I would always need to check which vaccines are live and which ones aren't, but these are the ones that I know of that are live. Polio, shingles, yellow fever, so avoiding those, and making sure that your other vaccinations are okay. In some patients, this isn't enough. We know that there are some patients who still get infections, and for some there may be a role for taking antibiotics long term, not to treat infections but to try and prevent them from occurring. And in some patients, again, even that's not enough, and we know that one of the things that CLL does is it reduces your normal antibody levels or immunoglobulin levels, and so for some people they need to be on monthly IVIG, immunoglobulin transfusions essentially, so we can take from blood donations the immunoglobulins from a normal population and infuse them into patients. I'm not saying that these bottom two should be for everyone, because they come with their own risks and costs, but for some people that's the right thing to do. And this is regardless of whether patients are on treatment for their CLL or not. So you've been diagnosed, we've got prognosis, we've talked about watch and wait. when do we actually start treatment? Now, I'm not going to go through all of this, but this is basically, there's a British guidelines that all hematologists should adhere to generally to tell us when we should be thinking about starting treatment. And this is very similar, and this is the International Working Group CLL guidelines. And basically, what they say is that people with the latest stages of CLL, so the Binet stage C or the Rye stage 3 or 4, should in everyday practice, so this is off trial, be having treatment. Those with active or progressive disease should be having treatment. What we don't know are the people in the intermediate stages. Should they be having treatment? I think you take it on a case-by-case basis. So the NGI stands for not generally indicated. For those with the lower stages, so it's not affecting their blood counts, not generally indicated. But who knows? Like I said, it is a research question. Is that still the case now that people with early stage CLL shouldn't be treated? We don't know the answer to that. So then just going back to the staging system, we know that these two, we should definitely be thinking about treatment at this point, possibly at the intermediate stages. So that's my initial bit, kind of to get you to where we are before we talk about the different treatments. And I don't know if anyone's got any questions that they're brave enough to ask now before we talk about different treatments. Yeah.
You spoke about CLL. What about SLL? Because a lot of that doesn't apply.
Yeah, so just so that everyone knows about SLL and CLL. So CLL is basically if you've got the clonal lymphocytes in your blood. SLL, we think it's the same disease, the same biology. It's got the same immunophenotype, so the same proteins on the cells. But this is when you've got essentially CLL, but it's purely in the lymph nodes. We can't pick it up in the blood. I think in terms of prognostic markers, because SLL is much less common, it's difficult to know, and we kind of try and extrapolate from them. But I think when we're looking at when to treat, it's still the same. So does someone have progressive disease? Are the lymph nodes getting larger? Are they becoming more of them? And if people are feeling unwell with it, then that would be an indication to treat. These things aren't absolutes, they're guides. Yeah.
So you talk about FCR as a gold standard.
We'll talk about the treatments now, but yes.
The question fundamentally is, there's a half-life to treatment where if you have to get this treatment again because it's going to come back, then the actual response is less than what's the last time it was.
Yes.
On that basis, is there a rationale that you can start treatment too early?
Yes, there is a rationale that you can start treatment too early. So I think in one of the chlorambucil studies where they randomized patients to chlorambucil and watch and wait, although it wasn't a significant difference, the patients that had the chlorambucil first of all, actually their overall survival was slightly worse than the people who watched and wait. And it's probably because the chlorambucil changed the biology of the disease. So we know that the treatment pushes the cancer essentially into finding ways to escape being treated, being killed off. So it does make it more aggressive. So things like TP53 mutation, we know if we test people when you're first diagnosed, the rate of how often we see it is much lower than if we treat people who've had 4 lines of treatment.
Dima, can I suggest if people write down their questions?
Okay, so sorry. How much time I've got? How much more time?
20 minutes, 25 minutes.
Okay. So, treatment. So, olden days, one drug. You were diagnosed with CLL, you needed treatment, we treated it with X, with chlorambucil. But we moved away from that now. Now, we mainly do this. We base it purely on patient-related factors. We're slowly getting better at personalizing it to the biology of the disease, but we're not quite there yet with disease-related factors. And one of the things which I have touched on before is that you need to think about what is the goal of treatment. Now, obviously the goal of treatment, you'd say to me, is cure. I want you to cure me from it. But if we can't do that, then what's most important? Is it that you want to feel better, that the symptoms to resolve, want a better quality of life? And when you look at trial data, you'll see that a lot of the early trials, when they want to give out their results straight away, will talk about response rates. So how deep a response do you get to the treatment? So is your disease gone by our powers of detection, complete remission? Or has it gone a bit, but we can still detect a bit, partial response? Or is it just stable disease? And now, as our powers of detection have become more sophisticated, Parag this afternoon, I think, will talk more on this. How deep a response do we need? So you might hear people talk on trials or even off trials about minimal residual disease. So one of the things that we do when we look at how well people are responding is, can we still see the CLL cells down the microscope? Now, I look at lots of samples every week down the microscope, but even with my expert eye, I'm not going to be able to pick up one CLL cell out of even 1,000. But with flow cytometry, which we talked about before, where you can look at the proteins on the cells, we can pick out one CLL cell in 10,000 normal cells. So our powers of detecting CLL have become much better. So what do we want to achieve with our treatment? But it's no good getting a treatment that gets rid of CLL by our powers of detection, but then it comes back a few months later. We don't just want a good response rate. We want that response rate to last for a long time. So as I talked about before, progression-free survival. I want it to last for as long as possible until the CLL comes back, and then until you need the next treatment. And ultimately, I think I want people to live for as long as possible with CLL rather than dying of CLL. But that's the goal. But I mean, we talk about often, a lot of you probably will have been told when you were diagnosed with CLL that it's an incurable disease. But actually, we've had a potential cure for even decades now. So there are a small proportion of patients who undergo a stem cell transplant from a different donor who are cured from their CLL. But the toxicity of the treatment is so much that actually, for every one person we cure, we'll probably harm a lot more and kill a lot more people from the treatment itself. So it's no good having a treatment that's going to cure a small proportion but kill a lot of others. So it's depth of response, but at what cost? So the toxicity is also important of the treatment. So treatment options. We've got our traditional treatment, antibody therapy, targeted inhibitors, and I will touch on T-cell therapy and immunotherapy, which many of you will probably have heard about in the news, and ASH will be full of talks about CAR T-cell trials. So chemotherapy. Chemotherapy is a blunt tool. It just kills rapidly dividing cells. The chemotherapy we give for one cancer will be the same chemotherapy we give for hundreds of other cancers. And that's why it can be quite toxic to the system. But having said that, it's very effective. We've become, with time, more sophisticated. We know the proteins that are on the surface of the CLL cells, so we can get antibodies that target those proteins. So the one that most of you will have heard of is the R from FCR, rituximab, which targets the CD20 protein on the surface of B cells. There are antibody-drug conjugates as well. Sorry, that slide implies that rituximab is an antibody-drug conjugate, which it isn't. So antibody-drug conjugates are antibodies which have chemotherapy attached to them. So rather than having a chemotherapy, which is going to kill all your rapidly dividing cells, this is to make it more targeted so that you get your antibody directing the chemotherapy at a small dose to the CLL cells, hopefully to minimize toxicity and the side effects of your drugs. And obinutuzumab is another antibody that's used in CLL. But stepping forward more, we've got targeted inhibitors now. So apart from just knowing what the proteins are on CLL cells, we also know what pathways are overactive that help keep the CLL cells alive and help them to keep dividing. So one of the pathways that we know are overactive are the B cell receptor pathway. So this is the cell surface of your B cells, and this is an immunoglobulin or antibody on the top. And when it's exposed to antigen, so like infection, it basically, through a cascade of enzymes, tells the chromosomes and the DNA in your nucleus of your cells to keep dividing, proliferate, to try and fight off this infection. But we know from all the mutations that we know in CLL that some of these pathways basically start becoming overactive even without the antigen to drive it. So they just start dividing and proliferating on their own without the initial driver, and that the checks that keep it in place are all dysregulated. So the targeted treatments that many of you may be on now are targeting different enzymes in this pathway. So I don't know how well this comes across, but ibrutinib targets this enzyme, the BTKs. You'll hear about BTK inhibitors. And there are lots of drugs at various stages of development that target different enzymes. And this is just one pathway. We know there are lots of pathways in CLL that help keep the CLL cells alive. Novel treatments, though, everyone thinks newer must be better. It must be more sophisticated, and it must have less side effects. But they have different side effects to the to the chemotherapy, but they still can be toxic if you get them. So we know that some of the novel treatments have potentially serious side effects, such as pneumonitis, colitis, increase your risk of infections again, and some of the side effects we don't know about. So ibrutinib, the trial may be going on 10, 15 years for the earliest trials. Who knows if they're going to have long-term effects of ibrutinib? We just don't know yet. So, what we know is actually the commonest reason for stopping novel drugs isn't that they're not working, it's that people can't tolerate them, but that we have other options now, and that also these inhibitors can have lots of interactions as well with other drugs. So just before talking about the specific drugs, I just wanted to give you an idea of how drug development occurs so that you know how the drugs get to everyday practice through the clinical trials. So someone has a drug that they think is going to be effective in CLL. They test it, first of all, in cell models. So they'll have CLL cells growing in the lab. They give it the drug. They see if the cells die or not. If it dies, they think, great, we might have a drug that shows activity. Let's see if it's going to work in preclinical models. So they'll have mouse models or perhaps monkey models of animals that have CLL or a CLL-like illness, and see, does this drug work in them? And once they're happy on the preclinical model that it shows activity, that the side effects don't seem too unmanageable, they start testing it in humans. So some of you may have heard of, been offered, or maybe on phase 1 trials. So this is the first time the drug is tested either in humans or in patients with CLL if they've been tested in other cancers. And the main aim of phase 1 trials isn't for the trial purpose, may not be for your purposes, is not to see how effective the drug is. It's actually to see, is this drug going to be safe? So it's looking for the side effects of drugs rather than how efficacious they are. Then they say, and also it'll be to look for dose. So they'll test people at different doses, starting at a very low, almost homeopathic dose, because we get very nervous that we're going to cause harm to patients, and then slowly build up the dose in different patients. And once they're happy that the drug is safe, then they'll move to phase 2 trials, and that will be to see in a cohort of patients, does my drug have activity? Does it work for patients with CLL? And once they're happy that their trial has activity, then we go into the larger phase 3 trials, where then they're randomizing people to, generally this is, randomizing people to either have the new trial drug or the standard arm. Can we see a difference in the outcome between those that have this my new fantastic drug compared to what we usually give? So with the phase 3 trials, they're randomized. You don't get to choose which ones you're on. So when you're looking at trial data, it's important to see what the endpoint is. Is the endpoint, when they're telling you about the new fantastic drug, the response rate? Is it the progression-free survival, or is it the overall survival? Each trial will publish different things either in conferences or in journals about these different things. And actually, the response rate might give us encouraging signals that a drug is good, but it might not actually translate, as you've already seen before, into an overall survival benefit. So it's important to really interrogate the results. And the other thing is, one of the issues with trials is that we're looking for large changes that lead to big improvements in the majority of patients. But I've already told you that CLL is different in different patients. If you've got different mutations, you might do better with one drug than you would with another. And so what we might do with trials when we're looking for big changes in responses and survival rates is miss drugs that have activity in the few that have this very rare mutation, because actually it gets missed in the big trial data. So it is one of the issues with trials that we might miss drugs that are very good for but a small proportion of patients. And obviously, the drug companies decide what trials they want to do, and so the financial implications do affect what trials we're able to run. And then this is just to show you how wasteful the whole trial system of drug development is. So this was an article published this year about the probability of drugs for cancer treatment, so generally, not just CLL, of going from a phase 1 trial right through to FDA approval. So FDA is when the American Drug Association approved the drug for everyday use in patients with a particular disease off a trial. So going from phase 1 to phase 2 trials, about over half of trials are deemed safe enough to progress to the phase 2. Of those that go to phase 2, about a third of them go to phase 3 trials. And of the ones that go to phase 3 trials, about a third of them go to approval. But overall, those phase 1 trials, drugs that are tested in phase 1 trials, only 3 to 4% of them actually ever get to being approved and being used off trial. So if you look at all the abstracts in ASH this year for CLL, I did have a quick look because they've just released what abstracts they're going to be. There's over 350 abstracts just on CLL this year in ASH, and there's so many conferences, they happen every year. There are so many different trials. Many of you will probably know trials that I've not heard of because it's impossible to keep up with them all. But there are all these phase 1 and phase 2 trials. Very few get to the large population studies. So it's quite wasteful if you think how expensive trials are to run. But what I would say is that we know that probably patients on trials do better than patients off trials. That hasn't been seen in all studies, and there's probably lots of confounding factors to this. So we know that the patient population of people that are on trials is very different to the patient population of people off trials. So the people on trials, it's very limited who can go on trials. They're very strict criteria. They'll want to make sure that you're very fit, that you don't have other health problems, and you don't have any other issues. Then we know that there's also a difference in education level between people that go on trials to people who don't. So there's lots of and socioeconomic differences as well. So there's lots of confounding factors, and whether it makes a difference if you're on a trial, you're more likely to be treated in a big center, which has more expertise, et cetera, et cetera. But yeah, so that's just a bit on drug development. So as I said, we've gone away from just treating everyone with CLL with the same thing. So this is how we basically decide on treatment. And I've got to thank Claire Dearden for this slide. This is hers. And it's mainly based at the moment on patient factors. How fit are you? How likely are you to tolerate the drugs we want to give you? So basically, are you go-go? Are you fit? Are you young? Are you slow go? You might be fairly fit, but you've got other medical problems that might have an impact on your disease. So you've got high blood pressure, you've got kidney impairment, or are you slow go, very frail, very elderly, not going to tolerate FCR chemotherapy very well? And we talk about age, but there's no strict age cutoff. And it's one of these things that people have tried to make different scores to see how fit people are so that they can definitely say this person, because they've got this criteria, this criteria, this criteria, they're fit, and this one not so fit. But actually, most people just go on their gut feeling. They make a general assessment of how fit someone is rather than strict age cutoff or criteria. So the fittest patients, FCR is the gold standard. So that's fludarabine, cyclophosphamide, and rituximab. So again, this is a survival curve looking at the progression-free survival. So for how long does someone live for before their disease comes back? And those who have FCR, so the rituximab added to chemotherapy, do better on progression-free survival than those who don't have the rituximab with their FC. And on the right-hand side is the overall survival. So although the difference isn't huge, there is a significant improvement in survival in those that have FCR compared to those that have FC. And the main toxicities are low blood counts and increased risk of infection. So actually, quite a lot of people on FCR don't make it through the 6 cycles because of the side effects of the treatment. And there is this increased risk, with the fludarabine especially, of secondary malignancy. So it does affect the normal bone marrow cells as well. So as I said, though, that people are different, and we talked a bit about prognostic factors. So this is the largest study on FCR chemotherapy, so the study I just showed you on the slide before, but it's splitting people's survival according to whether they're mutated or unmutated. So you remember the IGHV gene rearrangement. So those that were mutated and had FCR chemotherapy are up here. And they're doing very well, and we're coming up to now that 5, 6, 7, 8 years follow-up here for overall survival. And although a small proportion did die during this study, but if you're in the mutated group with FCR chemotherapy, actually the curve seems to be plateauing, that people seem to be doing well and living for many, many years before needing further treatment and surviving many years. So for IGHV mutated patients, this seems to be very good, effective therapy. This is another study which showed the same thing as well. We know the unmutated group don't do as well. They progress quicker and they don't survive for as long, and that's with FCR. And then we can also look and see there were other chromosomal rearrangements that they look to see the survival data. And we know that I mentioned the 17p deletion. People with 17p deletion of the FCR chemotherapy did a lot worse than other people. But this goes to show you how things can change as drugs change, or how we treat CLL. So 11q deletion was previously considered a high risk factor. People did worse with chlorambucil if they had deletion of the Q arm of chromosome 11. But actually with FCR chemotherapy, they seem to do quite well. So 11q used to be considered poor prognosis, doesn't look like it is with FCR. So it does change with the different treatments. So that was FCR. And then there was another trial that was looking at FCR versus rituximab and bendamustine, another chemotherapy, and that is used quite a lot in other B-cell malignancies, so like follicular lymphoma, which I'd mentioned before. So this group looked at whether, well, rituximab bendamustine, is it better than FCR for frontline, so for first treatment for CLL? And I don't know how well this is projecting, but basically this is looking at the progression-free survival, so how long someone lives for before their disease comes back. With FCR, those that had bendamustine had a shorter progression-free survival. And this was them splitting it according to age. So you won't be able to see all the different lines here, but basically it seemed like, regardless of whether you were over 65 or under 65, that FCR treated the CLL better than bendamustine. However, FCR comes at a cost, and it comes with more side effects than the rituximab bendamustine. So this is what I was talking about treating patients holistically. So it's not just about how well is this going to cure your CLL. I don't want you to get side effects that could be life-threatening in themselves. So we knew, and particularly in the older patients, that the risks of neutropenia, so your normal neutrophils going low, was much higher in the FCR arm compared to the rituximab and bendamustine, and the risks of infection were much higher in the FCR arm. So less toxicity with the rituximab and bendamustine, and this has led to a lot of people using rituximab and bendamustine for the patients that they think are fairly fit, but maybe perhaps they're a bit worried about this toxicities of FCR chemotherapy. So what about the patients that we think won't be fit enough for bendamustine? Because that also is quite a toxic treatment, and also you would have seen on the side effects causes infections and things. So we're back to chlorambucil, which, as I've told you several times, has been around for decades now. But we look to see, but other groups have looked to see, well, if we add antibody therapy to chlorambucil, can we make the outcomes better for these patients that we don't think are going to be able to tolerate more treatment? And so these are different antibodies that have been added to chlorambucil, all targeting CD20. So there is the rituximab, obinutuzumab is the G, and O is ofatumumab. And all of them show a better progression-free survival if you add the antibody therapy, that targeted treatment, to the chemotherapy. And so one of the things I said, that trials are dictated by drug companies, and what you'll often find is that the trial you really want to do will never happen, because no drug company in their right mind will pit their drug against another drug to see which one comes out better, because obviously they want people to still use their drug. But this was a trial looking at 2 different antibody therapies that were both produced by Roche, so they don't mind. And also they wanted their newer antibody therapy to show a better improvement to rituximab, because rituximab is off patent now. They don't get as much money for it, so they want to show that their newer drug that they can charge lots of money is better. So it's in their interest to do this trial. So you see how trials which dictate what we use there's lots of financial implications that drive what trials occur. But this was basically showing that obinutuzumab plus chlorambucil patients have a better progression-free survival. Sorry, this is time to next treatment of 51 months compared to those that have the rituximab and chlorambucil. So over 4 years until patients needed their next treatment with this. So we often use obinutuzumab and chlorambucil for those that we think aren't fit enough for something else. But we would always, if we have a clinical trial, offer the clinical trial. And again, going back to what I said, these are trials that have happened decades ago now, almost. Probably this was recruiting 15, 20 years ago, but still it's only 2015 that they can publish the long-term survival data. But this is just proving that the progression-free survival in this trial has translated to an overall survival benefit of adding obinutuzumab to chlorambucil. And similarly, this was presented in the European conference this year, showing a benefit to obinutuzumab compared to adding rituximab to chlorambucil. So I've told you about treatment based purely on patient-related factors. I think I'll come back to that. Sorry, that's a rogue slide. I'll come back to that slide now. Now, what happens when patients relapse? They need treatment, or perhaps they don't respond to their initial treatment. So this is where ibrutinib comes in now. So this is standard for everyone for relapsed disease. So disease that has gone away, or perhaps has never gone away, but it's come back, and we need to treat it. And this is one of the targeted treatments. So it's first-in-class oral BTK inhibitor. It's once daily. And it's licensed or NICE approved, I should say, in the NHS for patients who have received at least 1 prior therapy, or they've got high-risk features. So we know, I've already shown you that patients with 17p deletion or TP53 mutation did very badly with FCR chemotherapy. I'll show you some of the data which showed that perhaps they didn't do so badly with ibrutinib. So that's led to NICE approving ibrutinib first line for patients who've got those mutations or the chromosomal deletion. So we're moving on to tailoring treatment according to disease factors rather than just how fit someone is. But that's the NICE approval for ibrutinib, but it does have a FDA and the European equivalent license for first-line treatment in all patients with CLL. So there will be patients in the US and elsewhere in the world, and perhaps here who've got private health insurance, who will have ibrutinib first line, even if they don't have the adverse features. So this was based on phase 2 data to show this was patients who had relapsed from CLL and had ibrutinib, and this was looking at their overall survival. So you'll note here that the curves look very impressive, but you always have to look at the timeline. So this is still quite a short timeline. This is still only 2 years follow-up at the moment, and this was published 3 years ago. But the curve looks fairly good so far. And actually, when they split them according to those that don't have the 17p deletion compared to those who do, actually the ones that do, that we thought of as poor prognosis, don't seem to be doing as badly as the curves we saw with FCR, where it was coming down more like this. But again, it's short data. Short-term follow-up on this. And this was looking at using ibrutinib in other high-risk settings, and I'll come back to that shortly. So management of relapsed CLL, we'd repeat the analysis for the TP53. We generally want to check that patients don't have high-grade transformation. So 10 minutes, okay. We want to check that patients don't have high-grade transformation. So if you have a rapidly enlarging node, it's not enough for us to say, you've got CLL, this is just your CLL progressing. We want to check that it hasn't transformed into something different, something more aggressive, or potentially is something completely unrelated. I've already told you that patients with CLL have an increased risk of other malignancies. So we would generally want to biopsy patients if we can before starting them on toxic treatment that might not be the best treatment for them. At one point, and this was probably even within this year, if you had a very good treatment response to FCR chemotherapy, we weren't able to give ibrutinib because it wasn't funded to patients who'd had a long response to FCR, but they have changed that now, so we are able to give ibrutinib. But for some people, for whatever reason, ibrutinib might not be suitable, so we can give further chemotherapy again. So this was looking at so we knew ibrutinib was effective from the small phase 2 trial. So this was looking at a big study to see randomizing patients to ibrutinib or an antibody therapy in patients with relapsed or refractory CLL. And you can see here, again, this is progression-free survival, so how long someone lives for till their disease comes back. But patients with the ibrutinib did a lot better than the patients who had the antibody therapy. And when you look at trial data, you'll see that we look at the toxicity, so the side effects of the drugs based on something called adverse events. So we'll talk about how many people on the trial get a different adverse event. So here you'll see over 40% of patients on the ibrutinib had diarrhea, and we also grade the adverse events, so how severe it is. So obviously diarrhea grade 1, I forget the exact cutoff, but is 1 to 4 times a day, whereas grade 3 diarrhea is basically you're not off the toilet. So it makes a big difference. It's not just how many people get the side effect, but how severe the side effect is, which can be very debilitating. And you'll see that ibrutinib has lots of side effects. So just to mention some of them, diarrhea and arthralgia, which is pains in the joints, are very common, and they can be very disabling. We have lots of patients who struggle on ibrutinib. And this is one of these things where it's probably helpful to have doctors who've used ibrutinib lots before, because your tendency if someone gets a side effect is say, well, let's stop the drug, see how you go, and start it again shortly afterwards. But actually, it's better just to soldier through it with ibrutinib. So it will get better, but it takes time. And it will get better for most people, but some it might not. We know, so this scared people when the first trials happened with ibrutinib, that it's very good at mobilizing the CLL cells from your lymph nodes. So actually, when people first take ibrutinib, your white count and your lymphocyte count in particular goes up rather than comes down. So this scared the trial people at first. They thought that the people's disease was progressing, but actually it was all the CLL cells from the lymph nodes coming into the bloodstream before they were being removed. Significant bleeding risk. So patients, it's rare, but devastating if it happens, there are increased reports of major hemorrhage, the major bleeding that can be life-threatening. So we need to manage those if patients are having other things that might increase their risk of bleeding, such as surgery. There are unusual side effects as well, and then the other one that's a big issue is atrial fibrillation. We know that patients, as they get older, increase risk of atrial fibrillation, but certainly from all the big trials, and there have been several with ibrutinib now, that atrial fibrillation is more common with ibrutinib. So that's when your heart doesn't beat very well, it kind of flutters rather than pumps very well, and it increases your risk of heart problems and strokes. And we know that, so this is just talking about the lymphocytes going up before they come back down again on ibrutinib, and that this showed that it didn't make a difference to outcome whether you had the lymphocytosis or not. And this was a paper published looking at our UK experience of all patients that we know from our UK CLL forum who've been on ibrutinib. So this is more real-world data, although a large proportion of them were on the Resonate trial that I just mentioned to you. We found that patients on ibrutinib, the survival was good, whether you were old or young. That whether you had the 17p deletion or not, that people seem to do well in terms of overall survival with ibrutinib, but again, the timeline is short. That it didn't matter whether you had it up front or you had it second line or third line or more. So these people that had it after 2 treatments before they had the ibrutinib seemed to be doing well in terms of overall survival, or just as well as people who were having it up front. Again, timeline is short. And, but what we know is that people that didn't respond to it, so they didn't get the reduction in the CLL markers, did worse than those that did respond to it. I won't talk about that. One thing to mention is what we know is dose intensity is important in, with ibrutinib. So it's important not to miss the doses. So this group looked at patients, how much ibrutinib they took and what percentage of the ibrutinib they actually took. And they divided them into low dose intensity and high dose intensity. So that's whether patients were just forgetting to take it or they had to come off it because they were having surgery and things. And what we know is that patients who had long breaks or missed lots of doses did worse than patients that stayed on it continuously. So it is a drug that is very effective, but it's not, from this early data, doesn't look like it's curing patients of CLL, because as soon as you come off it, the CLL tends to come back. And some people do get a rebound phenomenon that if they come off ibrutinib because they need to for surgery, they feel a lot worse because they can feel their CLL progressing. So we know it's holding things in check, but it's not curing patients. So I mentioned that TP53 mutations, the chromosomal deletions, we know that we give ibrutinib upfront because they do so poorly with FCR. But I've told you that the patients that are unmutated for the IGHV seem to do not as well with FCR. So should we be giving them ibrutinib upfront? So this was looking at frontline ibrutinib versus chlorambucil. So now this is Resonate 2. So now they've shown it shows effect in the relapsed refractory setting. Does it show effect in the frontline setting? So giving it as the first treatment. And ibrutinib showed very good progression-free survival compared to what they were comparing it to, which was chlorambucil, which you could argue isn't the best treatment to compare it to. But again, this is about the trials where they want to show results. But this is progression-free survival. Overall survival, it still shows a significant difference, but actually it's not as big a difference as you might expect for the best new drug. And as I mentioned, it risk of atrial fibrillation. And I've already shown these graphs before, but this is just to highlight those that had FCR that were on the unmutated. They had the worse outcome than those that are mutated, but they still had 4 years before their disease progressed, and they needed further treatment. So although it's not as good as the patients with mutated disease, they're still getting a number of years without needing their next treatment. Again, this is showing long-term survival. This was for the unmutated. This one here is showing, so the ibrutinib for the unmutated and the mutated. So this is the yellow arm here. The dashed line is those that were unmutated, and those at the solid line is the mutated. So that's on the yellow lines. That actually, ibrutinib doesn't seem to differentiate. So people that have ibrutinib that are IGHV mutated or unmutated seem to do just as well. So then you might say, well, then if I'm unmutated, should I be having ibrutinib if I'm doing as well as the best prognostic patients? And some doctors, although this isn't NICE approved, again, will give patients with IGHV unmutated disease, they'll give them ibrutinib up front based on this data. So this is patients with private health insurance or around the world if they're able to give ibrutinib first line. And you could argue based on this data, you're better off doing it because they do just as well as the mutated on ibrutinib. But what we don't know is how will they do once they come off ibrutinib? What do we give them next? So I don't think it's a clear answer yet that we should, for unmutated CLL, be giving ibrutinib up front, because also what I showed you is that if you have FCR up front, you could still have ibrutinib as your second treatment. And actually, it didn't look from the data from the UK CLL forum that those that had it second did any worse than those who had it front line. So I think the evidence isn't completely there to definitely say everyone, even in the unmutated group, should be having ibrutinib up front. But different doctors think different things based on the same data. So it's how you interpret the data. Because we don't know which one's the best, there is a UK national trial, so there will be one near you for frontline therapy. And this actually is out of date, but basically we're comparing the gold standard FCR chemotherapy compared to different ibrutinib-containing regimes. So we're not doing this regime anymore. So we're randomizing between FCR and currently ibrutinib, and I think there'll be an ibrutinib and venetoclax arm as well. And this is still going on now. So we don't know what's the best thing to give up front. It's not just a question of how long does someone live till the next treatment, but is the ibrutinib going to make the CLL more aggressive in the future and harder to treat? We don't know. So just to touch briefly on venetoclax, because this is another NICE approved drug. So as it stands now, people generally will get chemotherapy first, then ibrutinib, and then venetoclax once they're progressed. This targets a different thing called BCL2. BCL2, we know, is an anti-apoptotic protein, so it stops the cell from being killed off and it escapes cell control. So that's a lot of cancers have overexpression of BCL2 to keep them dividing, to stop them dying off. Venetoclax targets that. And it's very effective in CLL. In fact, in some ways, it's almost too effective right at the beginning. So we know that CLL cells die off so quickly that you can get problems from the insides of the cells once the CLL cells have broken down, something called tumor lysis. So when we give patients venetoclax, we have to start off with a very small test dose and check for different markers in your blood to check that you're not getting too much potassium in your blood from the breakdown of all the CLL cells, and then we slowly build up in dose until we get to the final dose that we want to. So this involves a lot of checking, a lot of blood tests, and again, it's another thing where you need to be comfortable that your doctor knows how to manage you with venetoclax because of this, because you need to try and avoid problems with tumor lysis, which can cause kidney damage and can cause death in itself. But venetoclax showed excellent response rate. So as I said to you, when people wanted to show initial results to trials, they'll tell you about the response rate. How good is it at getting rid of the disease by our powers of detection? So you'll see things called waterfall plots, and this will basically say how much percentage of the CLL does disappear by our powers of detection. So this would be like an amazing trial. This would be the perfect waterfall plot. Everyone is responding, and actually they're responding to almost 100%. So we're getting rid of it by our powers of detection, and that's the key thing. But response rate's no good if it comes back again very quickly. So as I told you, you also want to look at the progression-free survival and the overall survival in trial data. And so that's just more about the response rate. So this is looking at the duration of response. How long does the response last? And it's doing very well. So it's a very effective drug, and it has an effect on overall survival as well. But again, early time points. We'll need to wait many more years before we see the long-term data with venetoclax. And this was the randomized big phase 3 trial that was published just this year in the New England Journal of Medicine that was randomizing rituximab and venetoclax against rituximab and bendamustine. And it showed a much better progression-free survival and, again, a significant difference in overall survival. But you'll see that the overall survival, the difference between the two arms, isn't as great as the progression-free survival. So I think a key thing to think about, which you don't always get that data from the trials, is what it's very well to tell me this is an effective drug, this is an effective drug, this is. What order should we be giving it in? Does the order matter? Does it matter if you have chemotherapy first, then ibrutinib, then venetoclax? Or would it be better to do it another way? And I don't think we know that at the moment. And then the other thing, obviously, you might say, well, ibrutinib's a good drug, venetoclax is a good drug, why don't you combine the two? Which is being done, and there are studies looking at that. So there's a Captivate study which investigated combining ibrutinib and venetoclax. And I won't talk about that because I'm sure Parag will mention it, because they are getting a very high MRD rate. So you know I was talking to you about the depth of response. So this is very sensitive ways for detecting the CLL, and they were getting a lot of patients who potentially, and they did talk about the cure word, were being cured by this combination because even by our most sensitive methods of detection, we couldn't pick up any CLL. So he'll talk about that, I'm sure, later on. But we don't know whether that's going to translate into duration of response. I'm not going to talk about adalimumab, which is another good targeted drug, but it's had a lot of problems with side effects. So it's still approved, but only if you don't have alternatives because of the risks of infections with it. Just highlighting that these aren't, they come with their own sets of problems. And the other thing is that we haven't talked about, and I'll probably end on it, is that these drugs, these targeted drugs, are, you take them for a long period of time. So at the moment, we'd say you take them for as long as you're responding and you're not getting side effects to the drugs. So you could be on ibrutinib for many, many, many years. So some people might say, I don't want a drug that I don't know what it's doing to my body, to have it for 10 years, perhaps 20 years. But we don't know when is it safe to stop it. Is it safe to stop it? And there are trials looking at whether we can give it for a shorter period of time, but that's another thing that we don't know. So some people might prefer the short, sharp shock of chemotherapy versus the long-term treatments. And I'll skip through that, and I'll just, one more minute, is that all right, Mark? Just to briefly mention immunotherapies, just because you will hear about it. There's a lot of excitement about it. So we know that everyone's immune system fights cancers. There's a theory that we all have lots of cancerous cells that come, but our own immune system kills them off, and it's only the ones that escape this control that become cancers as we know them. So can we use the body's own immune system to target and treat cancers? So two of the things that have been, two main groups of treatments that have been used more recently to see whether they can fight cancers are immunotherapies, and you might hear about PD-1 or PD-L1 inhibitors. So you've got, all of you have got T cells, I showed you on the bone marrow slide at the beginning, that we think fight in foreign cells or cells that they don't recognize. But they also have receptors on them that stop them killing your own cells. You don't want your T cells to kill all your normal cells. So the tumor cells evade destruction by basically having this turn-off signal activated. So this then stops the T cell from killing the tumor cell. But we can give antibody therapy that will stop this turn-off signal, allowing your own immune system to kill the tumor cells. And these have been shown to be very effective in certain diseases, such as Hodgkin's lymphomas. We don't know at the moment whether they're going to be effective in CLL or not, and there are trials underway looking at that. And there are also trials in CAR T-cell therapy. So CAR T-cell therapies are the latest buzz treatments in all hematological diseases and also non-hematological diseases. So this is basically, in a nutshell, you take someone's T cells from their own body and you grow them up in the lab and you add a virus to them that will allow those T cells from that patient to express antibodies that can target your CLL cells or whatever cancer you're trying to target. So there have been CAR T cells that are grown up to express something called antibodies that will target CD19, a protein that we know are on B lymphocytes. And you grow up all these T cells that you know have these targets, and you give them back to the patient. And then the theory is you've got a living drug that will hopefully stay in the patient for many months, perhaps years, and any time it sees a cancer cell which is displaying a protein on its cell surface, so the CD19, for example, then this will recognize it, target it, and kill it. So it's using your own T cells to kill the cancer cells. So there's a lot of excitement in this, and it has shown to be effective in some patients with acute lymphoblastic leukemia. The data with CLL, very early and very few patients, and it's not great at the moment, but it's still early days, so who knows at the moment. So this is one small trial which had about 13 patients in it, and it did look, but again, it's a short time, that patients that responded to this, so that their CLL went away by our powers of detection, seem to have a progression-free survival of over 2 years. And these would be people who've progressed through all standard therapies. But when it comes to overall survival, and I guess this is short data, so that's just 2 years there, the overall survival isn't so great at the moment with CAR T cells, but it's still early days. And I will probably leave it there.